Hi everyone, today I'm going to discuss about the serum ascites albumin gradient, quite commonly known and in short as SAAG. This gradient, the SAAG, is quite commonly used in general medicine, quite commonly used in hepatology, in patients with ascites, mainly to classify ascites, to find out an etiology of ascites. So before I start going into details of why the SAAG is used and how it is used, I'll just touch upon the concept of transudates and exudates, which is quite commonly used in medicine. So all of you might be aware of the concept of transudates and exudates. Whenever fluid starts to accumulate in any cavity of the body, we quite commonly classify it as transudates and exudates. For example, say you got someone with a pleural effusion. It is accumulation of fluid within the pleural space, and conventionally they are classified into transudates and exudates. So transudates are the one with low protein and exudates are the one with high protein. Now if you were to go through the common causes of transudates, they're mainly the failures. So you've got heart failure, you've got kidneys not working well, say nephrotic syndrome, you got liver cirrhosis, liver failure, producing a pleural effusion which has low protein content. And if you want to talk about exudates, you can divide them into infective, for example say a parapneumonic effusion, malignant, third is inflammatory, say autoimmune disease, some kinds of serositis that will produce increased exudate and pleural effusion. So as far as pleural fluid is concerned, this classification is pretty accurate, and you can make a list of differential diagnoses depending on whether on analysis you get a high transudate pleural effusion, a low protein pleural effusion, or high protein pleural effusion. However, this is when it comes to ascites, this concept is not entirely accurate, and there are various reasons why this concept can't be applied to the analysis and classification of ascitic fluid. The main reason is ascitic fluid doesn't behave like pleural fluid. So say when it comes to ascites, quite commonly if someone has got malignant ascites, for example, about one third 30% of people having malignant ascites will have a low protein ascitic fluid, which is exactly the opposite of what you see in a pleural effusion. Say most malignant pleural effusions will be exudative. Similarly, if you see patients with cardiac ascites, many of them have a high protein content, again which is completely the opposite of what you see in cardiac pleural effusion, which is a transudative type of pleural effusion, a low protein type of pleural effusion. So you can see there's quite a big overlap. There are also other reasons which can affect the ascitic protein concentration. For example, diuresis can increase the protein content of ascites. So if you got a patient say with a low protein ascites and you give them loads of diuretics and they have got significant diuresis post a lot of diuretics, the protein content will actually increase in the ascitic fluid. So if you measure the protein content before and after ascites, there will be a totally different protein concentration that you will obtain after diuresis. Okay, so there are these reasons, and there are many more reasons why the concept of exudates and transudates is not used in ascites. So to classify ascites, we use a different concept, and we use something which is called SAAG. So SAAG stands for Serum Ascites Albumin gradient. So the gradient, actually what it means is, it is the difference between the serum albumin concentration and the ascitic the ascitic fluid albumin concentration. And studies show that a SAAG, the serum ascites albumin gradient of more than 1.1 gram per liter is indicative of portal hypertension, and this is 97% accurate. So if you got someone with a SAAG of more than 1.1, you are 97% accurate that the etiology is portal hypertension in such cases. And so instead of classifying ascites as transudative and exudative, ascites is classified as a high SAAG ascites, that is an ascites due to portal hypertension, and a low SAAG ascites, that is ascites not due to portal hypertension. So I'm just going to end this little talk by just going through some of the common causes of a high SAAG and low SAAG ascites, and then we'll end the lecture. So you got SAAG of more than 1.1, that is a high SAAG, and a SAAG of less than 1.1. So SAAG of more than 1.1 is indicative of portal hypertension. The commonest cause that you need to know is cirrhosis of the liver. So the liver is replaced by fibrous tissue. There are a lot of liver parenchymal changes that take place, and it leads to increased portal pressure, that is portal hypertension, and you will get a high SAAG. Other causes are large or massive liver mets. So if you got a large volume massive liver metastases, you will have increased portal pressure, you will have portal hypertension, and you will get a high SAAG ascites. You will also see a high SAAG ascites in cardiac failure, mainly due to back pressure, and another not that common cause of portal hypertension that you need to remember is Budd-Chiari syndrome. It's basically a hepatic vein thrombosis. Also in Budd-Chiari syndrome you'll get a high SAAG ascites. With regards to low SAAG ascites, you should remember the following causes. So peritoneal carcinomatosis, wherein you will not have any portal hypertension. You will still have ascites because the peritoneum itself can produce a lot of ascitic fluid, and you'll get a low SAAG ascites. You get infection, mainly chronic infection like tuberculosis can produce tuberculous ascites. There won't be any portal hypertension in such cases, and the SAAG will be less than 1.1. Then you got nephrotic syndrome, which will lead to sequestration of fluid in the peritoneal cavity, but again, because it won't produce any portal hypertension, it will produce a low SAAG ascites. And you can also include pancreatic ascites associated with acute pancreatitis. There is no portal system involvement in this kind of pancreatic ascites, and therefore you won't see a high SAAG. So these are the common causes, the common classification of SAAG, a high SAAG ascites and a low SAAG ascites. This is how ascitic fluid is classified, and these are the common differentials of a high sag and low sag ascites. I think I will end the lecture over here. If you got any questions, you can always email me. I've kept the link below, right? So I hope you enjoyed this lecture, and I hope